G'day team and welcome back to Overheard in the Emergency Room. I'm Dr. Coyce, emergency physician, evidence nerd, and your guide through the messy, fascinating world of medicine. This is Quick Hits episode number 5. If you're new here, Quick Hits are short, punchy episodes where I take a question, sometimes from the inbox, sometimes from my own life, and give you the practical answer. There's no 45-minute deep dives, just me, a microphone, and something you can actually use. Today's episode is one of those from my own life episodes. Because last week I had an experience at my local pharmacy that I genuinely think every American adult needs to hear about, or has experienced themselves. So here's what happened. I went to pick up a nausea medicine, not anything exotic, a standard antiemetic. The pharmacist looked at the screen, looked back at me and said, "I'm sorry, we're out of network with your insurance. The cash price is $90 for a generic." So I did what I always do when something in the healthcare system doesn't quite add up. I asked a question. I pulled out my phone, signed up for GoodRx right there in the aisle, showed the pharmacist the coupon. $9. Same drug, same pharmacy, same 5 minutes. A 90% discount materialized out of thin air by clicking a button on my phone. And the question I want to answer today is one you're already probably thinking about. How on earth does that happen? And what should you do about it? A little bit of quick housekeeping before we dive in. If you find these useful, please like, subscribe, and hit the notification bell. And head to drcoyce.com for free patient resources, the companion blog post for this episode, and the full breakdown of how American drug pricing actually works. Right, let's get into it. Roughly 1 in 3 Americans report not filling a prescription at some point because of cost. That is one of the most concerning statistics in modern medicine because every prescription represents a decision a clinician made that this medication is more likely to help than harm. When you don't fill it, the whole calculation falls apart. And here's the kicker. A huge chunk of the time, the medication you're walking away from isn't actually expensive. It just looks expensive at the counter because of how the system is built. I want you to walk out of this episode with 3 things. 1, a basic mental model of who's actually setting the price of your medication, because it isn't the pharmacy and it isn't really your insurance company. 2, an understanding of why the same drug at the same store can cost you $90 or $9 depending on which contract you happen to invoke. And 3, a 3-step habit you can use the very next time you fill a script. This is one of those moments where a small amount of knowledge gives you real and immense amounts of power. Let's break this down. When you fill a prescription with insurance in America, there are 4 players in the room with you. Most people only know about 3 of them. Player 1, the drug manufacturer, the company that made the pill. They set what's called a list price or a sticker price. Player 2, the pharmacy. That's Walgreens, CVS, your local independent. They buy the drug from a wholesaler and dispense it to you. Player 3, your insurance plan, the entity collecting your premium. And player 4, the one most people have never heard of, the pharmacy benefit manager, or PBM for short. The PBM is the middleman that sits between your insurance and the pharmacy, and the PBM is doing most of the actual price setting. What's crazy to me, and very indicative of the capitalistic society we live in here in the US, is that there are 3 companies, OptumRx, Express Scripts, and CVS Caremark, that manage about 80% of all prescription drug claims in the US. They are owned, respectively, by UnitedHealth, Cigna, and CVS. So, if you have insurance through a major carrier, there's a very good chance one of these 3 is in the background of every prescription you fill. And here's what the PBM does. It builds the formulary. That is the list of drugs which your plan covers and at what tier it will cover them. Negotiates rebates with drug manufacturers in exchange for putting their drug on that formulary. And 3, builds the pharmacy network. It signs contracts with specific pharmacy chains setting how much the pharmacy gets reimbursed for each script. So now we can answer the first half of my question. Why was my pharmacy out of network? Because my insurance plan's PBM and Walgreens did not have a contract that worked for both of them. Walgreens, unlike CVS, doesn't own a major PBM, so it's frequently the chain getting squeezed out of networks owned by its competitors. When that contract breaks down, the pharmacy is out of network for that plan, and you get told to pay cash. But the second half is more interesting. Why was the cash price $90 when GoodRx instantly dropped it to $9? Here's the part most people miss. That $90 cash price is what's called a usual and customary price. Essentially, a sticker price the pharmacy sets, often artificially high. Almost nobody actually pays it. It exists as a contractual reference number and as the default for uninsured walk-ins who don't know to ask for anything else. And when you swipe a GoodRx coupon, you're not really paying cash. GoodRx has aggregated contracts from a bunch of different PBMs. PBMs that do have contracts with Walgreens. So when you hand over the coupon, your transaction is processed through one of those PBM contracts. You're piggybacking on a negotiated in-network price between Walgreens and a totally different middleman than the one your insurance company uses. So just read that again, because it's the whole game. There is no single real price for your medication. There are multiple negotiated prices, and which one you pay depends entirely on which contract you happen to invoke at the counter. Before we get to what you can actually do, let me address the most common pushback I hear when I tell this story. Dr. Kois, this sounds too good to be true. What's the catch? Why would the pharmacy lose $81 just because I waved my phone? Notice the rhetorical move here. That's called the too good to be true fallacy. The assumption that if something dramatically benefits you and you wouldn't understand why, it must be a trick. In healthcare, that instinct often keeps people from taking advantage of completely legitimate savings. Here's the truth. The pharmacy isn't losing $81. The pharmacy was never going to get $90 from most patients in the first place. The $90 is a sticker price. At $9, the pharmacy still makes a profit, just on a lower margin. The strategy is volume over margin. They'd rather sell you the drug at $9 than have you walk out empty-handed. A few other tools worth noting about briefly. Cost Plus Drugs. This is Mark Cuban's company. They cut out the PBM almost entirely. They buy directly from manufacturers, add a flat 15% markup plus dispensing fees, and tell you exactly what they paid. For a lot of generics, it's the cheapest option, period. Amazon Pharmacy, particularly if you have Prime membership. It's worth comparing. They have manufacturer copay cards. If you're on a brand name drug, almost every manufacturer has a copay assistance program. A 5-minute search on the manufacturer's website often turns up something. Note that if you're on Medicare or Medicaid, federal anti-kickback rules generally exclude you from these. But if you're on commercial insurance, they're fair game. Patient assistant programs. For expensive specialty drugs, foundations like Needy Meds and the Patient Access Network can be life-changing. Ask your prescriber's office. They often have a staff member who navigates these. And one tactical move you can do. Ask the pharmacist directly. What's the cash price? Is there a coupon that's cheaper than my insurance copay? Until very recently, pharmacists were sometimes contractually forbidden from telling you that information unprompted. Those were called gag clauses. 44 states have now banned them, but patients still don't know to ask. 44 states have now banned them, but most patients still don't know to ask. So what should you actually do? Here's your 3-step plan for every prescription, every time. 1. Ask. Before you hand over your insurance card, ask the pharmacist, what's the cash price on this? That single question changes the conversation. 2. Compare. Open GoodRx, open Cost Plus Drugs, check the manufacturer's website for a copay card. It takes 90 seconds in the parking lot. 3. Choose. Pick the lowest legitimate option. If GoodRx is cheaper than your insurance copay, use GoodRx. You're allowed to do that. It's not cheating, but one caveat for my listeners on Medicare and Medicaid, you generally can't combine GoodRx with your federal coverage, and using a coupon means that purchase doesn't count towards your deductible or out-of-pocket maximum. So just run the math. Sometimes the coupon still wins. Sometimes the insurance does. The point is to actually check, not to default. One of the 5 non-negotiable foundations of long-term health on this show is having a primary care physician. Not just for the obvious reason, continuity of care, catching things early, but for this reason too. A good primary care relationship means you have someone to call when your pharmacy says $90 and you're wondering whether there's a cheaper alternative on the same therapeutic class. Many medications have a $4 generic equivalent that does the same job. A 30-second conversation with your doctor can save you hundreds of dollars a year. The system will not advocate for you. Your primary doctor will. That's why we put having one in the foundation. And that's your quick hit. If you got value from this, I've got 3 quick asks for you. 1, what's the next quick hit you want me to answer? Drop it in the comments, send it through the website, or DM me on the socials. These episodes are entirely listener driven, and the questions you send are what keeps this series going. 2, like, subscribe, and hit the notification bell so you don't miss the next one. 3, share this episode. Send it to a family member who pays whatever the pharmacy tells them to pay. Send it to the friend who's been splitting pills because their medications are too expensive. For the full companion blog post, references, and free resources, head to drkois.com. It truly makes me sad to have to make this episode in the first place, because I think we should care enough about people's health and about members in our community that we simply change our system to include universal single payer coverage, which would solve all of these problems. But in the meantime, I'm Dr. Kois. Let's chase less bad days and more good decades together. I'll see you next time, and hopefully not in my emergency department.